All right, good afternoon. We'll do a quick sound check.
You're good.
Awesome. Awesome. We're thrilled to join you today, and thank you so much for your time and attention. We're excited to learn together. Um, I had the distinct pleasure of working with Dr. Feinberg and Jay Mason to put together this presentation today regarding management of Hep C in pregnancy, the postpartum period and infancy. In some of the emails that came out, sort of shortened the management of Hep C in infants and postpartum patients. We obviously know that this is a recurring issue across our state. I'm really proud of our state and the initiatives like this to not only inform and empower, but to help eliminate Hep C, which I very much believe we're capable of doing. And it takes joint efforts between the adult and the pediatric world. So without further ado, I'm going to go on silent, and I'll turn the slides for Dr. Feinberg until we get to my part. But we're thankful for your time and attention. We welcome interactivity throughout.
Great. Thank you so much, Jacob. Okay, we have no disclosures. Next slide. So here's a list of the objectives that we're going to cover today. And we will leave you with resources in the end. Next slide. All right, well, very briefly, I want to give you some background about hepatitis C in pregnant women in our state. Next slide. I talked about this extensively in the first session in this series. I'm only going to show you a couple of slides, but here we go. This is data from the CDC. It was published last September, so it's really quite recent. And you can see that we are way, way far away have the highest estimate of hepatitis C among pregnant women in the United States. Kind of a scary slide, actually. And in the middle of 2022, we decided that we would make perinatal hepatitis C a reportable condition. And that year, half year, we had already clocked 11 confirmed cases. So we really do have an issue and it needs attention. Next slide. And here's a map from the Bureau for Public Health that shows you where hepatitis C is concentrated in our state. Unsurprisingly, there's a great deal of hepatitis C among pregnant women in the southern coal fields, where everything related to the drug epidemic in our state is sadly at high rates. So you get an idea here. It's the counties that are white doesn't mean they don't have any. They just don't have as much hepatitis C among pregnant women as the counties that are in some shade of red. Next slide. So there's the background. We have a significant problem. So I want to move now to the current guidelines on the treatment of Hep C in pregnancy. Next slide. So these are the recommendations from the AASLD, stands for the American Association for the Study of Liver Disease, and IDSA is the Infectious Disease Society of America. And these two professional organizations have joined together to create a set of guidelines. Typically, you expect these guidelines to come from the CDC, but I can't explain to you why the CDC didn't approach this, and a need for guidelines, you know, was quite clear. What's good about these guidelines is they not only uh, developed and updated by experts, but they are reviewed and updated constantly. So they are really the most current information that you can get. So, of course, what we would like to do is be able to screen and diagnose hepatitis C in women of childbearing potential before they get pregnant. And so all of the guidelines say, well, let's try to get that done. Um, it's not only a matter of reducing the risk of hepatitis C transmission to the infant, but actually women who have chronic hepatitis C have more rocky obstetrical paths to delivery, and the infants have more problems. So it's more than just transmission. It's also the health, the morbidity, the health and safety of the pregnant woman and her unborn and then infant child. During pregnancy, the very important thing, aside from making it understood to the pregnant individuals that the risk is about 6% for mothers that only have hepatitis C. It doubles for mothers who have both hepatitis C and HIV. But it's really, really important to have ongoing follow-up and testing for both the mother and the infant, because the majority of these women are lost to care after they deliver, and that's really problematic. There is also, interestingly, about a 10% incidence of spontaneous hepatitis C clearance after childbirth, and so that's another good reason to make sure that these women get appropriate follow-up, because maybe they'll be one of the lucky 10% and they won't need to be treated in the future. Next slide. During pregnancy, uh, the guidelines say that women with hepatitis C really should receive the same prenatal and intrapartum care that's appropriate for them from an obstetrical perspective. There's no intervention that we know of that will reduce mother-to-child transmission other than potentially treating during pregnancy. And really, care has to be individualized for that woman's medical situation. So we do advise to get routine liver function tests and a hepatitis C RNA PCR, or what we refer to colloquially as the viral load, at the initiation of prenatal care, so that we can appropriately evaluate the degree of liver disease. One of the problems that we see in pregnancy when the woman has chronic hepatitis C is that they are highly susceptible to developing the intrahepatic cholestasis of pregnancy. And that can have serious consequences. So in women who develop itching or jaundice during pregnancy, then they should be evaluated very, very rapidly for whether they're developing cholestasis of pregnancy. And then, as I already mentioned, there is this increased risk of adverse maternal and perinatal outcomes. And so this is clearly a situation where the woman's care needs to be coordinated by an obstetrician, somebody with expertise in maternal fetal medicine. These are women who should be followed in high-risk pregnancy clinics, and then, of course, need the input of either hepatology and infectious disease from the adult perspective, and as Dr. Kilgore will describe in detail in a few minutes, the appropriate follow-up and evaluation from a pediatric perspective. Next slide. So I'm going to just share a case with you to sort of go over some of the issues that can come up. So this was a 31-year-old woman who had chronic hepatitis C and was begun on Mavorette at the end of November of last year. She had a negative pregnancy test before starting treatment, and then again several weeks later, prior to starting the second month of pregnancy, the second month of treatment, excuse me. Mavorette is only given for 2 months, but she had a positive pregnancy test soon thereafter. So at the point of this positive pregnancy test, she had completed 6 of the 8 weeks of treatment. And at that point, her viral load was checked and it was undetectable. Now, this is not entirely surprising because these medicines are incredibly potent, and it is really possible to cure somebody with less than the FDA approved length of therapy. So next slide. Let's go into this issue of what's available for pregnant women and children. So we do have, you know, not a clear enough pathway for screening and treating before conception. Actually, the Public Health Service guidelines from the U.S. Department of Health and Human Services says everybody 18 and older should be screened for hepatitis C at least once in their lifetime. But this is not really happening on a routine basis, and it's certainly not happening, uh, uh, as it should among women who are becoming pregnant. Um, we have medication that's approved, of course, to be used before women become pregnant and after they complete breastfeeding. And we certainly have wonderful medication at appropriate doses for children. But here in the middle of this cascade of care during pregnancy, breastfeeding, and infancy up to 3 years of age, we don't have anything that's approved by the FDA. And as I said before, the loss to follow-up is huge in this patient population. It's over 50%. And so keeping these women in care so they can be monitored is really important. Next slide. So the issue has been raised by a lot of different people about, well, maybe we should treat during pregnancy. We do this for HIV, and in some cases, we do this for hepatitis B. And there are some significant potential benefits of treating at this point. First of all, this is a time in a person's life where they typically will have, if they enter prenatal care, they'll have health care coverage. They will have the motivation to spare their infant from developing hepatitis C. And then the downstream benefits, of course, is that if you cure hepatitis C in a person, then they can't give it to anybody else. I've already mentioned the hep C associated morbidity of pregnancy and delivery. And of course, there's always psychological benefit to curing anything that's chronic. These are the people who come in with, they cry when you tell them their viral load is undetectable. And then, of course, the risks that I've mentioned during pregnancy, certainly cholestasis, but also preterm birth is quite common. Babies are born small for gestational age, so there's fetal growth restriction. There are all these other things that are part and parcel of the chronic hepatitis C. And then, of course, we're hoping that the baby will not indeed get hepatitis C. On the other hand, we don't know that much about the safety data of these DAAs. Stands for direct acting antivirals, and it's to distinguish the medications we use now from interferon, which is what we used 20 years ago and is very nonspecific and also doesn't work very well. So we do have some safety data, but it's more limited. And I'll show you some of that in the next couple of slides. Next slide, Jacob, please. So we do have guidelines about what should be done during pregnancy. The American College of Obstetrics and Gynecology says, do not do this. The hepatologists and infectious disease docs really have been evolving their stance. Next slide, I'll show you what that is. So, of course, if hepatitis C is diagnosed during prenatal care, uh, then counseling really has to be aimed at educating that woman about the risk of vertical transmission, educating her about when hepatitis treatment would be possible, and making plans to set that up. But people have, again, based on our success in avoiding the vertical transmission of HIV and the fact that the classes of medications we use for HIV are the same classes of medications, nucleoside analogs and protease inhibitors that we use for hepatitis C. So that now the combined hepatology infectious disease guidelines say, well, you can consider treatment in pregnancy. This has to be absolutely individualized, has to be on the basis of a profound discussion between the woman and her physician about the potential risks and benefits. So this is a change. Next slide. So there is, in fact, a study of treatment in late pregnancy. Treatment starts in the 26th week, so well after the period where organ formation is completed. And this is an ongoing multi-center prospective evaluation of sofosbuvir and velpatasvir, which is for which the trade name is Epclusa. It started a few years ago and is aiming to enroll 100 pregnant infant pairs. And there is, as of several months ago, a site at Marshall. So if you are taking care of or helping to manage pregnant women with hepatitis C, then come back to this information. This is maybe information you want to share with folks. Next slide. So interim assessments of this study have been presented. Here's data for the first 24 participants. Preterm birth happened in 3 of these 24 pregnancies. All of the 17 women who have completed therapy and have been evaluated for cure have indeed been cured, and none of the infants have been infected, although out of 17 people, you wouldn't, with a 6% transmission rate, you wouldn't expect much. But we have also not seen any cholestasis of pregnancy, which is quite terrific. Next slide. And while there have been no discontinuations of medication due to side effects, there have been adverse events that have been reported both in the moms and the infants, but none of the infant adverse events were related to the drug, whereas almost 1 in 5 of the maternal adverse events were considered to be drug-related. And you can see on the upper part of the slide, a lot of it is GI side effects, which is not that common when you're not pregnant, but on top of pregnancy, it makes sense to me that there were 8 women who experienced nausea and vomiting. And there was 1 congenital anomaly and was thought to be unrelated to treatment. Next slide. So here's what's happened with this. So in fact, the drug was stopped after 6 weeks. The recommended further management was to repeat the viral load 12 weeks after stopping treatment, which is normally the time point for assessing cure. We did know it after 6 weeks that there was no detectable viral load, but it wasn't a complete course of therapy. But if the viral load is undetectable at this what we call the SVR12, the sustained virologic response 12 weeks after the last pill, if it's undetectable, then this mom is cured and no further treatment is going to be necessary. But if it is detectable at that time point, then she will need to be retreated. And our recommendation was to switch to Epclusa, make sure that there was no resistance development. And Epclusa, unlike Mavorite, is given for 12 weeks instead of 8. Next slide. There's not a lot to say about this other than that if a woman is not cured of her hepatitis C before she conceives and she opts not to be treated during pregnancy, then after she gives birth and finishes breastfeeding, you can certainly initiate treatment. So, I mean, there's nothing more to say to it than that. This is, the ideal time would be preconception, but, postpartum is certainly better than not treating at all. Next slide. So I'm going to end with a slide about preventing future transmission. And a lot of this, given what the behavioral history of most of these women is really based on the principles of harm reduction. So from preconception all the way through prenatal care and the postpartum period, these are women who, if they are injecting drugs, need to be referred to syringe services, need to be offered treatment for substance use disorder, need to be offered family planning access. The women I have cared for to a person had not been offered any kind of access to family planning, and not a single woman that I've cared for had a pregnancy that was planned. They need to be screened not only for hepatitis C, but for hepatitis B and HIV and syphilis, which are sadly all too common in this population. Of course, they need to get appropriate education about hepatitis C, what it does, how it's transmitted, and how easily it can be cured. And we really need to ensure that these women have access to hepatitis C care in the postpartum period. As I've mentioned a couple of times, this is a period in which a lot of women just fall out of care. And, we can't cure them if we're not seeing them. And all of this involves the obvious things, reduction of stigma, getting people to reduce behavioral risks, monitoring the mom and the baby, and preventing reinfection. And I think that should be the last slide, Jacob, if you advance. I think this is yes. So let me stop there and let me turn it over to my colleague, Dr. Kilgore, to talk to you about infants and children with hepatitis C.
Thanks so much, Dr. Feinberg. Gosh, you just a true mastery in this. It's fun to listen to you. There's so many parallels that we're learning in the pediatric world, and you covered so many of the integral pieces that were initiatives at the state level as far as statewide reporting. Really thinking about the dyad, right, of how we can care for both mom and child. And really, I have to give credit to if you're able to hear the most recent ECHO presentation by doctors Lanata and Gerlach about diagnostic confirmation and sort of management in that early period. You're going to hear some of the things reiterated, even some of their slides, because you can see just like in the adult world, there are elements that will work you up to okay, now we're going to manage. Where do we go from here? I try to take off my pediatric infectious diseases hat and live in the general pediatrics world. Although I'm not a general pediatrician, we're so thankful for all the pediatricians and family practice docs and advanced practice practitioners and all that we do. And so I encourage questions that are granular at the end that really get into the nuance of this care, noting that I'm happy to slip that hat right back on in the ID world of how we manage and how we help co-manage. But really, the groundwork is laid at the level of interaction and forming those relationships in most of the general practitioner world. So diagnostic confirmation is key, right? So you heard just a phenomenal presentation by Dr. Feinberg about risk factors that would put us in the scenario where the child would be exposed. And so we want to just reiterate what diagnostic confirmation means. So remember, we now have updated guidelines as far as how we would think about hepatitis C testing. I think a lot of us are used to in the pediatric world, Red Book, which is sort of the holy text in pediatrics. That's a combination of the American Academy of Pediatrics and the Infectious Diseases Society of America sort of guidelines put together, a very comprehensive source. It is red. We love colors in pediatrics. Was testing at 18 months. Now that has changed as far as recommendations, and that data was shared by Dr. Lanata regarding the use of Hep C RNA testing, quantitative, not qualitative testing, based on the test statistics being 100% sensitivity, specificity, positive and negative predictive values, which was phenomenal. As you can see here, if you would follow this algorithm down as far as Hep C and RNA testing, starting around 2 months of age, that says 2 to 6. We'll get into some of those categories a little bit further out. But if detected, it talks about current Hep C infection and linking to care. And so I think there's some real interesting nuance there. Is what does that mean? It depends on where you are. Where can you link to care? What can you do as the provider initially caring for this patient to ensure that you're queuing him up for the most optimal care possible? And then we also think about, Dr. Feinberg had briefly mentioned as well, as the potential is you're positive now. Is there a chance for clearance? And that was covered by Doctors Gerlach and Lanata as well, as the potential for clearance over time, and thus some of the monitoring that we'll do in those first couple years out to 3 years, where where antivirals are approved now for children to see if they can clear on their own. If you're outside that period and you're greater than 18 months of age, we're looking more now at using that Hep C antibody testing. Hep C antibody testing, a little bit more familiar, labs a little bit more available. And then the cost difference is notable, but we know that we have to wait outside that time period that antibody may be passed transplacentally from mother to infant. And so you could get a lot of false positivity within that first 18-month period. That's why it would shift. and you have sort of a different algorithm that you would follow if reactive, going then on to the Hep C RNA quantitative study. If detected again, you're going to land in that same box as far as current HCV infection linked to care. Think about monitoring over time. Um, when we talk about linking to care, I think at some point that involves subspecialty involvement. Where I trained at Marshall, as far as med peds, when we were covering the pediatric ICU, our phone was actually red. So when the red phone went off, I still think of this visceral reaction that I have to the red phone going off and a transfer coming in. So I thought I would pay a little homage there, but it really depends the facility in which you provide care. Depending on where you are, you may be linking them to care with a pediatric infectious diseases provider. It may also be pediatric gastroenterology, and in fact, depending on what subspecialties are available, that may go on to be pediatric hepatology. At Marshall, and specifically, we aid with the initial screening process because, as Dr. Feinberg mentioned, it's all about looking for co-infection, HIV, syphilis, et cetera. As we know, these things tend to run together. And we often help with that first stage, but it's actually our pediatric gastroenterology team that we work collaboratively with who's more familiar with the insurance approval process, et cetera. We also share a nurse that we end up doing the management. And you'll see a difference at different facilities. And I encourage discourse at the end to know what other facilities in the state do as far as helping get these patients triaged to the right place. So you have diagnosis, you're talking about subspecialty involvement and linking to care. And so really it's about timing a referral. And I've tried to meet with pediatricians and pediatric providers across the state about when would you all like to see these kiddos? Like when would be the best time to refer? If it's something that we can do in our office and we're saving, a referral that they're driving 2, 3 hours and we're going to sort of monitor the viral load over time, see if there's clearance. And we know that, antivirals are not approved till 3. Are there things that we can do in our office? Or, we sort of have a different population of providers that sort of feel like they want to get them to care immediately, and we can help sort of coordinate in that space. By no means am I here to take away autonomy. Our job is to work collaboratively, and it's really what you're comfortable with. And like I said, there's just a growing comfort level in the non-subspecialty world to feel like they want to manage these patients closer to home. I think that's awesome, and it's about empowerment then in that space and how we can work together. So when we think about long-term monitoring, this is a slide you can tell from doctors Gerlach and Lanata. It's like we said, it's about you may actually clear the virus or you may not. And so it requires pretty close interval following. So depending on where you fall in that initial screening, were you in the 2 to 6 months or beyond, or did you land 18 months? The initial visit, these are things that I would consider that we would consider in our ID clinic here at Marshall. So we'd begin to think about Hep C genotype. We would get, I think LFT sometimes is a hair of a misnomer. That's no offense to anybody, but I really would call them transaminases because the function of the liver is separate and different. So looking for liver inflammation, right? We would get CBC with differential, and we're looking at platelet values again, being a sort of a functional unit of liver and status and consumptive coagulopathy type piece. And then also we're looking for co-infection, right? So depending on when they land, are you doing an HIV fourth generation screen where the antibody antigen you're at that time period, or are you going to need to do an HIV RNA PCR? Same principles, right, as far as transplacental passage of antibody and making sure that we use the appropriate test there. It's also very much about counseling. It's about engaging family members, about natural history, and you can imagine to a certain degree, there's just a lot of questions of what do they do? Are there special things? And we'll talk about a little bit more nuance of counseling. Can they go to daycare? Transmission and prevention. These are excellent times to connect on that level. And we actually have sort of come up with a nice sheet that I'm happy to share that sort of engages the AASLD guidelines and sort of puts it into a more layman's terms. It's a good time to address the possibility of treatment for the positive guardians, right? And again, Dr. Feinberg has eloquently walked us through that. But don't just think about mom in that scenario. You can think about dad or whoever's involved. And I don't want to put inappropriate labels. So whoever the guardians may be, you want to try to link them to care. And we've been really lucky to be able to do that with some of our adult programs here in family practice, internal medicine, and adult infectious diseases and GI as well. And then obviously it's about encouraging appropriate vaccinations, including hepatitis A and hepatitis B, which we know we want to make sure that we have documented immunity to before we would consider management and treatment. So if you've already referred to us and we've seen them, we will help coordinate this. If not, these are some things that you would consider at different age intervals over time after that initial visit, depending on when it lands. At 18 months, we're going to repeat a quantitative Hep CRNA, see if it's still positive. Have we cleared? If negative, then you can consider documented clearance plus minus whether you're going to get the antibody right, depending on where you're at. Again, CBC, CNP includes those transaminases, coags, and then you're looking at some of that hepatitis B workup and anything else you hadn't been able to do as far as co-infection, HIV, syphilis, et cetera, that you'd want to consider. Onward to 3 year, which is when we're starting to get really serious about the potential of treatment because treatment is now approved down to that age. You can see those repeat lab studies, and then you're starting to stage the child, right? So liver ultrasound, I think, is important. You're starting to get some scoring systems, and then really assessing readiness to treatment because there are some patient characteristics we need to consider. We've triaged things like G tubes in place and poor feeding, and you have to think about what that would mean. And so I strongly encourage referral before that 3 year of age mark, just so we can make sure that we're shoring up some of those things. We can start with insurance approval, which can take time, and just making sure we navigate some of the more granular components of some of the counseling that would be involved. I added these because this is if you I always think, go to the data, go to the guidelines and make sure you're following them. And I won't go through each one of these, but we've essentially taken the AASLD and IDSA. This would be straight from their recommendations and sort of put them into a little bit more of a cohesive, sort of natural progression of how we want to follow patients over time. And we feel like we've met these boxes uh, um, more than adequately. I'm sure the rest of the facilities across the state are doing the same, but it is rooted in a place just like the adult recommendations are found that certain things we want to make sure we're checking boxes before we ready them for any sort of management. Counseling is key. I think the most time spent in the room after talking about infection versus non-infection, potential clearance, it's about counseling. It's about creating a welcoming environment, a supportive environment. It's about ensuring, just like Dr. Feinberg said, that we're removing the stigma, right? And I think the thing that we talk about the most is, can they go to kid daycare? Can they play with other kids? We have other kids in the home. What do we do? Honestly, the most reassuring thing to tell them is just treat them like you would any other kiddos, except for box two, where you can see that just talking about risk and routes of transmission and avoiding direct blood exposure, right? Sharing toothbrushes and razors. Nail clippers is a big one when we think about it, right? Sort of sharing nail clippers and what could be there. And then the use of gloves and dilute bleach to clean up blood. That's about it. Again, nice and packaged in a sheet for a family so they can have it discreetly. We've asked some families have asked us to work with their daycare, which is totally fine. We're happy to pick up the phone and talk to them. But this is the most important piece, right? They need to be whatever normal means to them, and we need to reduce some of those preconceived notions in the office. And a great time to counsel the guardians as well. So who do we treat? Direct acting antivirals, just as Dr. Feinberg said, are approved at age 3 years and above, and we treat regardless of disease severity, but it is about staging disease and having an understanding, and then considering the presence of extrahepatic manifestations that you'd want to consider to be on the lookout for. And obviously, as we consider treatment for all children, regardless of disease severity, the real key is, do we have evidence of fibrosis, cirrhosis? Is it compensated? The idea is to pick these children up early in the screening process. The whole idea of moving the screening to 2 to 6 months of age was Hep C. Even Hep C RNA quantitative was recognizing that they may still have the ability to clear over time, but it's the loss to follow up, right? It's when you see that one patient come back at 20, 25, 30 years of age who's in acute liver failure and needs a transplant, this is it's our service to them. This is our duty, right? To help prevent that. Oftentimes when they didn't even have a chance or didn't even know, right? So you're going to end up getting Child's Pew scores, which we're not going to get in today. No quiz at the end, no quiz questions on that. But really, it's also about picking up co-infection, and you heard that also for mothers, right, at the time of delivery for risk factors as far as transmission, et cetera. Once you've gotten there, there's basically three drugs we consider for children. I'll say the drug name Mavorix, Epclusa, and Harvoni, but you can see the common name components there. As mentioned, Mavorix an 8-week duration, Epclusa and Harvoni 12 weeks. It really depends on the genotype of the virus, tolerance, the ability to be able to take certain granules as far as formulation. I think these things less probably important for the general practitioner, but happy to talk about that because the general practitioner will be integral also in the follow-up, right? We're fine to get treatment started, but do we really need them to come back, every 2, 4 weeks? Can we do that through the PCP? And so helping not navigate those, I'm happy to help field some questions and actually may turf some of those to our PGI team, who is really an expert in that space as well. And then we talked about, eradication, this golden 12-week period, this 3-month period that after completion, do we see normalization of transaminases? Do we see undetectable viral load? And the idea of late relapse after this SVR is super uncommon. And really the reappearance of HCV at that point should raise concern for reinfection. I'm going to echo exactly what Dr. Feinberg said. You really want to think about the potential of reinfection at that point and what the risk factors would be. And I think that's why it's so important for counseling for these patients and why it's important to screen them into their adolescent and adulthood because they are at risk for reinfection based on other practices. So I'll stop there. I'll re-engage. I know that we have another potential speaker as well as Dr. Feinberg, but thank you for your time and we'll welcome some discourse here at the end.
All right. Does anybody have any questions right now before we move on? Feel free to unmute, put it in the chat. Hey, we got a quiet group today. All right, so if you want to go ahead, Jay, did you want to go ahead and bring up your slide? We can just kind of keep trucking along.
All right, everybody. Thanks, Chantry. Thanks, Dr. Kilgore, Dr. Feinberg. Appreciate it. All great information. Really, this slide and what I'm going to talk to you about today is just really to let you know what tools are in the tool belt as far as resources that you can access as a provider. Anybody really on the care team that would really, have questions about these kind of patients or hepatitis C patients in general, HIV. And you're on one of them right now. Project Echo is one of those resources. We do have a hepatitis C HIV Echo where you can present de-identified cases. It also can count for your Medicaid consult if you need that approval, which is great. So, it's easy to sign up. We'll send this slide around so you can actually access the link and things like that. But if that is something you're interested, it is available to you, no cost. You can do CME as well. And then the West Virginia HAMP program, which Dr. Feinberg talked about at this Echo, is also another great resource. A little bit more one-on-one, a little bit more in person, in virtual. But again, great resources to have CME, can count for that consultation for Medicaid if you need it. Just know that you got resources available to you that don't cost you anything or are not going to be a burden to you to access. Because just like Dr. Kilgore and Dr. Feinberg said, we've got to treat these patients. We got to try to treat them as early as possible. So hopefully we can, with some of these resources, be able to do that. If you have any questions about that, please don't hesitate to reach out to myself or Chantry about Echo, and then obviously Dr. Feinberg for West Virginia HAMP. That's it. My spiel is very short. So that's it for me. We can open it back up for questions or anything like that. One thing I just did want to say, I know this is the last session for the pilot. We're going to take some of the evaluation data that you guys have been providing to us, those pre and post data. We're going to get together with the team again, see what best course of action as far as moving forward. One thing we've hopefully have noticed is that maybe the short burst of sessions might be the way to go, where we can, hit you, 4 sessions at a time or something like that. We're just going to try to take that all into account as we try to plan things moving forward. So more information will come out on that as well. So thank you. I'll turn it back over to Chantry.